Hello, good evening. So, I just discussed the first part, which I found that it would be useful to discuss the grading system. Now, I'm going to discuss a brief about the cloacal extrophy. So, this sources which I am going to use whenever I will discuss about cloacal extrophy, these four sources I have opted. So the first is Kelalis King textbook of pediatric surgery. Second is Koren textbook of pediatric surgery. Third is Scraft pediatric surgery, for which we have updated edition now. And the fourth is Hall Snyder ARM textbook. As of now, the most of the content that I have taken is from the Hall Snyder ARM textbook. So I am going to discuss cloacal extrophy, which has also another name called as vesico-intestinal fissure, or one can call it OEIS. So it is a very severe congenital anomaly of infraumbilical body wall, which consists of exomphalos or omphalocele, one exotrophied cecum flanked by two hemibladders which contained ureteric orifice, and we have already discussed in the grading part how this hemibladder or a bladder can be arranged. Then the cecal plate. So cecal plate is a proximal opening leading to ileum, that is elephant trunk deformity. I have already shared the image in the story section there, where you can go and see in the Instagram page. And there are two appendiceal openings, then the distal opening, which is leading to blind bowel segment, which we can call as hindgut or tailgut. Now the next important thing, how it will appear in male or female. So gender assignment is a topic of debate, and it is very tough to assign a gender at a stage when we are clinically uh, doing assessment for the neonate. So in both the gender there will be a pubic bone separation, that we call it pubic bone diastasis, and in males one can see there will be a split penis, each pubic bone segment carrying a corpus cavernosum and a hemiglans. So that's why it is difficult to reconstruct this one. And in female, clitoris will be split and a vaginal duplication will be seen. So anatomy prediction with a certain degree is not possible in this kind of anomaly, because of there are endless variations which we have already discussed around a central theme. So we will briefly discuss about the embryology of cloacal extrophy. So the two main important hypotheses which are used to describe cloacal extrophy is, first is Marshall Muke hypothesis. This is most commonly used. In this, abnormally enlarged cloacal membrane will prevent the normal mesodermal migration. So if there will be abnormal mesodermal migration, it will lead to that the as further development progresses, it can rupture prematurely. So the timing of rupture will determine that what we are going to have as an anomaly. So if there it will be a early rupture, if it will be a early rupture, then it will lead to cloacal extrophy. If it will be a later rupture, then it will lead to CBE, that is classical bladder extrophy. And if this thing happens further late, then epispadias will occur. Then the second hypothesis is Thomala hypothesis. So Thomala hypothesis says that the persistent low insertion of the body stalk creating a wedge effects which prevent normal midline closure, rather than we say that this is solely a cloacal membrane defect. I have already discussed about Manjoni-Rancellet grid. So if we talk about incidence, it is around 1 in 2 lakh, sorry, 1 in 2 lakh to 4 lakh individuals. But as per Fetal Care Research Foundation, that is situated in Chennai, India, the incidence of cloacal extrophy in the Indian population is somewhere around 8 per 1 lakh, which means around 1 in 12,500 cases. Genetics is a little, I would say, a complex task, so we might discuss it in the form of a short image or something like this. Now we are going to discuss the risk factors in the development of cloacal extrophy. So we have to remember that a bimodal age group during pregnancy, that means the later ends, means someone with a young age or someone with the late age, like somewhere less than 20 or more than 30, 31, will be a risk factor for the development of cloacal extrophy. And then as per few reports, it has been mentioned that the in vitro fertilization predisposes to the development of complex body wall defect. Then the next we are going to discuss what are the anomalies associated with cloacal extrophy. So skeletal system, here we can see in the skeletal system there will be a symphysis pubis diastasis that we have already discussed, and then vertebral column defect in the form of posterior element anomalies, sacral dysplasias, hip subluxations, so much so common that one has to assess the all these bony things also while doing an infantogram for these kind of neonates. And also lower limb anomalies, the commonest one among these is CTEV. Then the renal anomalies, the renal ectopia is the commonest anomaly, followed by agenesis, which is seen in around, I mean, the chances of renal agenesis is around 30 times higher than the classical bladder extrophy. Then hypoplasia and duplication can be seen. Then the genital anomaly include undescended testis, duplication, or the absence of internal genitalia. Followed by we are going to discuss CNS anomalies. So these babies have spinal dysraphism, which can be either in the form of meningocele or myelomeningocele or spinal lipoma or something like this. So these anomalies can have varying presentations. Then GI tract, there might be blind ending colon, malrotations, duplications in the form of colonic duplication and appendiceal duplications, which have its own bearing on the management of the illness. Then short bowel, which can either be an anatomical short bowel in the form of when we see the cecal plate के एरिया पे कैसा अरेंजमेंट है बावल का, और अ फिजियोलॉजिकल शॉर्ट बावल सिंड्रोम ड्यू टू द माइलोडिस्प्लेसिया और डिफेक्ट इन द absorptive capacity. That omphalocele is noted in majority of the cases. एंड pelvic floor में अगर आप बात करेंगे तो there is a hypoplastic levator muscle in majority of these babies. Then if we talk about the management of the cloacal extrophy, it is approached through neonatal operation, which further divided into standard approach and variation in the neonatal surgery. So standard approach, first we will have to exclude the lethal uncorrectable serious anomalies, followed by if there is a open MMC before embarking on the cloacal extrophy, we have to manage this open MMC, we have to repair or excise the thing. Then first thing comes in the management is omphalocele closure, so which either can be a primary closure can be done or a staged closure. So staged closure is usually achieved by prosthetic pouch placement or mercurochrome painting of the sac. So it includes then followed by separation of the ileocecal plate, so bowel plate, and then the later on tubularization of the segment is done, which is further brought out as a endostoma in the form of tail gutostomy. So associated small bowel malformations are corrected simultaneously. And if there is a duplicated tail gut, which can be later used in the form of bladder augmentation or vaginal replacement, then the suturing of hemibladder in midline is done to achieve a classical bladder extrophy like status. Then someone will ask what are the variation in neonatal surgery. So the first thing is the in situ bladder augmentation. So in situ bladder augmentation is further divided into either one can do a proximal ileostomy, which is not recommended nowadays because it is associated with more water and electrolyte loss, and we going to discuss the failure to thrive component and the disuse atrophy of the distal or the hind gut or the tail gut. That's why it is not recommended nowadays. And the one of the commonest thing which is recommended is tail gut ostomy. Then few people recommend that the leaving the hind gut in situ for the later use, either a bladder augmentation के form में या फिर vaginal replacement के form में. But as per most of the literature, it has been mentioned that if we are not going to use this distal bowel or this tail gut, that it is never going to sort of gain its actual length or the diameter, which is having a impact on overall management. Then the second thing is primary pull through of the bowel. So अब इसको करना है या नहीं करना है, ये किस चीज़ पे डिपेंड करता है कि whether your neonate or the child is able to produce a more solid stool or not. Because if you are going to primary pull through and the child is having some form of anatomical and physiological short bowel, so then it will be a very very extensive perianal excoriation. So one need to look after this factor also. Then the second thing is, if a child, as we have already discussed, there is a wide spectrum of this illness. So if any of the child is having a normal anus, then we can say that it is correctable with minor procedures like cutback anoplasty. These kids are usually truly continent of the stool because of the normal anus formation. Then the primary neonatal bladder turning. So this can be done although as a using the advantage of neonatal pelvis pliability, but one the surgeon need to ask a question whether the neonate will be able to tolerate the procedure or not. Or other way around can ask if there will be a closed bladder, whether the adequate capacity and compliance will be preserved or not, or it will just simply increase the intra-abdominal pressure, which sometimes because of the like increase in the severity of the intra-abdominal pressure can lead to respiratory embarrassment. So one has to be aware of this thing also. Then the nutrition and growth in infancy and childhood. So the most important survival issue, how is the nutrition of the child. So majority of these kids have a problem with this thing and usually end up in failure to thrive, and this is seen in around half of the cases by first year of their life, and around one third of the children by the time they reach their fifth birthday. So the physiological short bowel syndrome is relatively common secondary to myelodysplasia, and the anatomical short bowel syndrome is seen in around 15% of these neonates. Then the add-on factors which is responsible for physiological short bowel syndrome is neurogenic bowel dysfunction and the repeated bowel surgeries, which can ultimately lead to malabsorption. So the quality of life issues is the repeated surgeries, the various dates of the surgeries which are associated with the different subcomponent of this illness, which includes anorectal, genitourinary, neurosurgical and orthopedic reconstructions. Then the anorectal reconstruction in the fecal continence, as I've already discussed, the true continence is something which is very rare and usually associated or seen in those children where already an anus is present. So truly continent anus with spontaneous passage of stool and no soiling is rare, and no soiling and no enemas. So abnormal nerve supply to perineum or some form of associated frank or occult myelodysplasia is seen in around 90% of the neonates. That's why these children have a problem with the fecal continence. So pull through procedure करना है या नहीं करना है, or if these child are having some form of extensive excoriation, so much so that one has to revert the pull through procedure and end up into the abdominal stoma. So this is something has to be pre-decided and has to be well versed whether we are dealing in a great way with the bowel management thing, whether the neonate or whether the child is able to produce a solid stool or a semi-solid stool. And then whenever we are going to do a pull through procedure, it is usually done through the anterior sagittal approach, and then the enteroplasty is done. Then the second most important is urinary reconstruction and continence. Truly, urinary continence is a rare phenomena, and the contributing factors are the myelodysplasia and the iatrogenic nerve injury while doing the cecal plate mobilization or the bowel plate mobilization. The aim is to achieve a adequate urinary reservoir with the continent catheterizable port, which can be either done in the form of bladder turn-in or either by bladder augmentation, where the various part of the bowel, or whether if there is a duplicated bowel segment, that can be used, or there are reports of using stomach also. So cystoplasty, and then the continent catheterizable port, which I mean in the form of appendix, or the dilated ureters, or ileum. So these can be used. Then the gender assignment and genital reconstruction is a very big task in these babies because of the highly separated pelvic bone and the hemiphallus. If we are going to talk about male gender, and similarly with the female having the split clitoris along with the vaginal duplications. So these are various problems, and all obviously the magnitude of the genital reconstruction surgeries has a impact on the psychosocial life of these babies, and also the other surgeries and the ambulation procedures. Other surgeries include the neurosurgeries, sometimes the extensive gut resections, and then the management of the upper tract injuries by doing or by dealing with all these things. And then the orthopedic problems include CTEV sometimes. So the long term management is has an impact. And then the gynecological management starts when the females start having, if those are having a normal internal organs are having started having menarche, then the problem started beginning. So how to deal with gynecological management, it itself is a challenge, and the psychosexual problems we are already discussing throughout the discussion. So these are something the challenge that one need to be aware of. And the parental involvement is something which is very 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 important, I would say, whenever we are going to manage these babies. So this is a brief about the chapter. If someone is interested, can read Hall Snyder, and then there are very very good books we have, as I've already discussed all the sources.